Margaret was 68 years old, retired from 30 years of teaching 4th grade in a small town outside Knoxville, Tennessee, and she was the kind of woman who brought homemade banana bread to her annual physical. Not because she was nervous, because she was grateful. She trusted her doctor completely. She had no reason not to. She had been going to the same practice for 11 years. Her blood work was decent. Her blood pressure was managed. And when her physician of a decade retired and handed her off to a younger colleague, she figured it would be fine. People retire. Life goes on. The new doctor reviewed her chart at their first appointment, ordered a few updated screenings, and at the end of that visit, almost as a footnote, mentioned that Margaret's bone density scan showed some thinning. Not unusual for her age, he said. Very common. He recommended a procedure, a minor one. She was in and out in under 2 hours. No general anesthesia, no overnight stay. Her daughter drove her home and made her soup. 3 months later, Margaret was back in that office, this time with a fracture. Not because the procedure failed in the way procedures fail, but because no one had asked Margaret one specific question before recommending it. No one had looked at her full picture. No one had connected the medication she had been taking for acid reflux for 6 years to the bone density issue they were now trying to fix. And the procedure they recommended, well-intentioned as it was, did not address the root. It addressed the number on a scan. I think about Margaret a lot. My name is Whitney, and I'm a physician. I've been practicing medicine for over 2 decades, and for the last several years I have focused almost entirely on preventive health for adults over 60. I started this channel because I kept seeing a version of Margaret's story repeat itself in different exam rooms, in different states, with different patients, and I got tired of watching it happen. The appointments are too short, the specialists don't always talk to each other, and older patients, especially women, are often handed a recommendation with the full expectation that they'll simply say yes. Because the doctor said so, because they trust the system, because they were raised to be polite in exam rooms. I want to change that. What I'm going to walk you through today are 4 of the most commonly recommended medical procedures for adults in their 60s, 70s, and 80s. Procedures that are sometimes absolutely the right call, and sometimes not. The difference between those 2 outcomes often comes down to a single question. One question that Margaret was never given the chance to ask. One question that, had it been asked out loud in that exam room, might have changed everything that followed. This is not about distrust. I want to be very clear about that. I am not here to tell you that doctors are bad or that the medical system is your enemy. I am here to tell you that the system is rushed, and rushed systems miss things. And the person most likely to catch what gets missed is you, an informed you, a you who walks into that exam room with one specific question already in your pocket. There is a concept I come back to again and again in my practice. I call it the longevity lens. It means looking at any medical recommendation, not just through the question of whether it works, but through the question of whether it works for you, at this stage of your life, given everything else that is happening in your body right now. Because the research on procedures in older adults is very clear on one thing. A procedure that is appropriate at 50 can carry a completely different risk-to-benefit ratio at 72. And most patients are never told that. We are going to talk about all 4 procedures, and I'm going to give you the exact question to ask before you agree to any of them. But first, I want to hear from you. Drop a comment below and tell me where you are watching from today. I read them. I read every single one, and I'll see you in the next section. The first procedure I want to talk about is elective spinal surgery, and I want to start here because it is one of the most frequently recommended interventions for adults over 60, and one of the most misunderstood in terms of what it can and cannot realistically deliver. Here is what typically happens. A patient comes in with chronic lower back pain. Maybe they have had it for years. Maybe it flared recently after a long car ride or a season of gardening. An imaging scan, usually an MRI, is ordered. The scan shows something: degenerative disc disease, spinal stenosis, a herniated disc. The doctor looks at the image and says, "Here is your problem, and here is how we fix it." Surgery is mentioned. Sometimes it is framed as the logical next step. Sometimes it is framed as the only step. What is rarely mentioned is this: a landmark study published in the New England Journal of Medicine found that for many common spinal conditions in older adults, surgical outcomes at 1 year, 2 years, even 4 years were not significantly better than outcomes in patients who received structured physical therapy and pain management instead. Not in every case, but in enough cases that the question of whether surgery is necessary deserves a real conversation, not a referral form. Here is the biological reality. As we age, almost everyone develops some degree of spinal degeneration. It shows up on scans the way gray hair shows up in the mirror. It is real, but it is not always the cause of the pain. I have had patients in my practice whose imaging looked alarming and who were nearly pain-free, and patients whose scans looked relatively mild who could barely get out of a chair in the morning. The scan is not the whole story. It never is. What I want you to do before agreeing to elective spinal surgery is ask your physician this: have we exhausted the non-surgical options with the same rigor we are applying to the surgical ones? That is the beginning of the one question I will give you in full before this video ends. And the answer to that question will tell you a great deal. The second procedure I need to address is cardiac stenting for stable coronary artery disease. Now, I want to be careful here because stenting absolutely saves lives in the context of a heart attack or an acute cardiac event. I am not talking about that. I am talking about elective stenting, recommended after a routine stress test or imaging study shows some degree of arterial narrowing in a patient who has no active symptoms or has only mild, manageable ones. This is more common than most people realize, and for years it was standard practice. The logic felt airtight. You see a narrowing in an artery, you open it, you prevent a future event. Clean and simple. Except the research stopped supporting that logic for stable patients, and the medical community was slow to update its recommendations. A major trial called the ischemia trial, published in 2019, followed thousands of patients with stable coronary artery disease and found that for this specific population, adding a stent to optimal medical therapy did not significantly reduce the risk of heart attack or death compared to medical therapy alone. That finding sent ripples through cardiology. It is still being debated. But the core implication for you, sitting in that exam room, is that the word elective should always trigger a question. I had a patient, a 71-year-old retired postmaster from rural Georgia named Donald, who was referred for stenting after a routine cardiology follow-up. He called me first, which is not always something patients do. We talked through his full picture. His symptoms were minimal. His medications were not fully optimized. He went back to his cardiologist and asked the question. They ultimately decided together to try an adjusted medication regimen first. 2 years later, Donald is walking 3 miles a day and has not had a cardiac event. That is what one question can do. I want to hear from you right now. If you have ever been recommended either of these procedures, type the number 1 in the comments below. You are not alone, and your experience matters. Stay with me, because what is coming next includes the 2 that surprise people the most. The third procedure on this list is one that I want to approach carefully, because it lives in a space where the intentions are genuinely good and the outcomes are genuinely mixed. I am talking about aggressive cancer screening follow-up procedures in older adults. Specifically, the cascade of interventional procedures that can follow an initial screening finding in someone over 70. Here is how it typically unfolds. A routine screening, a colonoscopy, a low-dose CT scan for lung nodules, a PSA test, returns something, an abnormality, a shadow, a number slightly outside the reference range. And from that moment, the medical machinery moves forward with tremendous momentum. More imaging, a biopsy, sometimes a surgical consult. All of it feels responsible. All of it feels like due diligence. And for many patients, it is exactly the right path. But there is a phenomenon in geriatric medicine that does not get nearly enough airtime in the general public, and it is called overdiagnosis. It is not a fringe concept. It is documented extensively in the medical literature. A 2020 analysis in the British Medical Journal examined screening outcomes in older populations and found that certain slow-growing abnormalities detected in patients over 75 are statistically more likely to be outlived than to become the cause of harm. In other words, the finding was real. The intervention carried real risks, and the patient may well have lived longer and better without ever knowing the finding existed. I am not telling you to refuse screenings. Please hear me on that. Screenings save lives. What I am telling you is that a finding is not automatically a mandate, and the cascade of procedures that follows a finding needs to be evaluated through your full picture: your age, your overall health, your other conditions, your own stated priorities for quality of life. I had a patient named Sylvia, 77 years old, a retired librarian from outside Baton Rouge, Louisiana, sharp as a tack and fiercely independent. A follow-up scan after a routine screening found a small pulmonary nodule. The referral chain that followed moved very quickly. Within 6 weeks, she was being scheduled for a bronchoscopy and a possible surgical consult. She came to me between appointments, frightened and confused. We sat down and looked at her full picture together. The nodule was small, it was not growing, and Sylvia had 2 other significant health conditions that made any surgical intervention genuinely high risk. We brought those factors back to her pulmonologist. Together, they agreed on a watchful waiting protocol with repeat imaging instead. Sylvia is 79 now. The nodule has not changed. She is still gardening. That is the difference between a procedure being available and a procedure being right for you. The 4th procedure is the one that surprises people most. And I want you to stay with me on this because it challenges something most of us were raised to believe about taking care of ourselves. The 4th procedure is routine dental surgery in older adults, specifically complex extractions, implants, and extensive oral surgical procedures performed without a full review of the patient's cardiac medications, blood thinners, and bisphosphonate history. Here is the mechanism that most patients are never told. A class of medications commonly prescribed for osteoporosis, called bisphosphonates, the brand names you might recognize, can, in a subset of patients, affect the blood supply to the jawbone in ways that make oral surgery genuinely high risk. The condition is called medication-related osteonecrosis of the jaw. It is not common, but it is serious when it occurs, and the critical point is that many patients presenting for dental procedures have been on these medications for years and have never been asked about it by their dental provider. And their prescribing physician has never been told about the planned dental procedure. This is the gap that the rushed system creates. Not malice, not incompetence, fragmentation. The right hand does not know what the left hand is doing, and in that gap, older patients get hurt. A 2021 review in the Journal of the American Dental Association found that medication reconciliation before invasive dental procedures in adults over 65 was inconsistent across practices in ways that the authors described as a significant patient safety concern. That language in a peer-reviewed journal is about as close to an alarm bell as academic medicine gets. This is the part most people never find out. And what I am about to give you in the final section, the one question and the exact framework for using it, is what ties all 4 of these together into something you can actually use the next time you are sitting in that exam room. Do not go anywhere. Here is the one question. Are you ready? Write it down if you need to. because I want you to have it in your hand the next time someone in a white coat hands you a referral form or schedules you for something before you have had a chance to think. The question is this: given my age, my full medication list, and everything else happening in my body right now, what is the evidence that this specific procedure will improve my quality of life more than the best non-procedural alternative? That is it. One question. But I want you to notice what it contains, because every word is doing work. It says, given my age, because the evidence base for most procedures was built on younger populations, and outcomes shift meaningfully as we get older. It says my full medication list, because as you saw with Margaret and her acid reflux medication, and with the bisphosphonate patients facing dental surgery, the interaction between what you are already taking and what is being proposed can change the entire equation. It says everything else happening in my body right now, because no procedure exists in isolation. Your kidneys, your heart, your bone density, your cognitive baseline, they all affect how you respond to intervention and how you recover from it. And it says quality of life, not just survival, not just the elimination of a finding on a scan. Because for adults in their 60s and 70s and 80s, how you live matters as much as how long. This question does not make you a difficult patient. It makes you an informed one. And any physician worth their license will welcome it. Now I want to give you what I call the 5-question protocol, because that one core question is the center, but it works best when it is surrounded by 4 supporting questions that help you build the full picture before you agree to anything. The first supporting question is, what happens if I wait 30 days and we reassess? For any elective procedure, a 30-day window for further evaluation, a second opinion, or a trial of non-invasive treatment is almost always medically reasonable. If a provider resists that conversation, that resistance is itself important information. The second supporting question is, who else on my care team needs to know about this before we proceed? This is the fragmentation question. This is how you catch the gap between the dentist who does not know about the osteoporosis medication and the cardiologist who does not know about the planned spinal procedure. You become the connector, because the system often will not do it for you. The third supporting question is, what does the recovery actually look like for someone my age, not the average patient in the study? Recovery timelines in medical literature are frequently drawn from populations that skew younger and healthier. Ask specifically what the realistic recovery looks like for a person with your health profile. Ask about cognitive effects if anesthesia is involved. Ask about fall risk during recovery. Ask about the impact on the medications you are currently managing. The fourth supporting question is, can I speak with a patient who has had this procedure at my age and with a similar health background? Not every practice can arrange this, but asking it signals that you are engaged, that you are serious, and that you expect to be treated as a full participant in your own care. Those 4 questions, wrapped around that one central question, form the 5-question protocol. And I want you to take it into every procedural recommendation you receive from this point forward. Here is what I need you to hear as we close today. You have spent decades taking care of other people, your children, your parents, your colleagues, and your communities. You have earned the right to walk into a medical appointment and ask hard questions without apologizing for it. The system is not designed to slow down for you. That does not mean you cannot slow it down yourself. One question, asked calmly and clearly, can redirect an entire care plan. I have watched it happen. Margaret's story did not have to end the way it did. Yours does not have to either. If this video gave you something useful, please share it with someone you love before their next appointment. Not after, before. Subscribe if you want to keep having this conversation, because we are just getting started. And leave me a comment telling me which of these 4 procedures surprised you most, or if you have a story of your own. I read every single one. I'm Whitney. Take care of yourself, and I will see you in the next one.